now like to invite Dr. Sunitha Mahesh and Dr. Chaithra. They'll be speaking on newer immune therapies and practical applications.
At the outset, I would like to thank the chairpersons for accepting to chair this session on all the therapies which we use in our day-to-day practice while managing the IVF and the infertility cases. So I also thank Dr. Chaithra for accepting this invitation to talk to us about the immune therapies. So it's going to be like a dialogue delivery. Okay, we have come to the end of this session, and I know it has been very, very exhaustive, right from morning 8:30 to now. We have heard to a lot of lectures, and we want to have this discussion as a crisp take-home messages. If we talk about immunology, we can talk the whole day. We can have one day complete CME only on immunology. But today we'll be, ensuring that the right message is being taken. Yes, we have come to the successful end of this session, and we all know that for successful implantation, we need a good quality embryo and also a receptive endometrium. In the morning, we have heard that embryo contributes to 70% and the endometrium contributes to 30% to have a successful implantation. But the endometrium also is under immunological factor to have a receptive endometrium. So now, what are the immune therapies? We'll not go into the basics of immunology in reproductive medicine, but we'll try to understand this topic on immune therapies. So what are immune therapies, Dr. Chaithra?
The basic immunomodulation is very much required to have a successful pregnancy outcome. Like we all know, 50% of the composition is from the paternal origin, and the immune system, the maternal immune system, is supposed to accept it, harbor it, nourish it for the entire 9 months. So immunomodulation is where we are going to change the immunity for the acceptance of the embryo to have a successful implantation and progression of pregnancy. The commonly used ones could be oral. We're just going to be going through all those which we commonly follow these days. We will be rushing through IVIG, lipids. We will talk about anti-TNFs. We'll talk about the world famous HCQS. So this is how we will progress. Yes, ma'am. So, ma'am, when should a clinician stop labeling a case as an unexplained RIF or an RPL and start actively investigating the immunological causes?
Yes. So whenever, we do the procedure, we do the IVF, we do the embryo transfer, and then later on the patient comes back with a negative report, we are like left on the crossroads. We are like, we don't know what to do. But should we start investigating all? So there are guidelines which have defined, recurrent implantation failure and recurrent pregnancy loss. So based on that, like we are going to decide when we have to start the immunological evaluation. But there is, it's very, very difficult to say that this is the stage when I will not be evaluating for immunology, or to say that this is when I will start evaluating for immunology. Sometimes we might miss a patient who is an immune positive or immunologically incompetent patient by not evaluating her or by not giving her the right kind of treatment. But according to guidelines, recurrent implantation failure has been defined as failure after 2 good quality embryo transfers, especially the blastocyst, and also like for recurrent pregnancy loss, it has to be like after 2 miscarriages with normal karyotype. But when they are there, if they have failed, these are the subtle red flag signs. What should be the choice of investigations and what should be the therapies? Like what should be the basis to decide which investigations we should be doing?
Like ma'am said, it is not essential for us to wait for them to have 2 blast transfer failures, well-evaluated embryo transfer failures. What if she comes with a typical butterfly rash? What if she is having features of a pre-existing autoimmune disease? Then it is way too better to evaluate her in the way to beginning. Otherwise, yes, we will step or we will wait, as the incidence of an autoimmune disease being the cause of RIF or an RPL is slightly on the lesser side. So once we have a good transfer and we fail, that is when we start the evaluation. So the commonly done evaluations will definitely be to looking into the endometrial profiling. We will talk about the NK cells, the natural killer cells, which has a very vital role in the trophoblastic invasion and development of the embryo. We will also be doing the entire paneling. When I say panel, we will look not just at the NK cells, we will look at CD56, we will look at CD19, 3, 4, the Treg cells, I call them the guardian of the uterus. We also will definitely want to look into the cytokine profiling, the signaling proteins, which guides us as to what immunomodulators has to be given to the patient to have a successful implantation.
Yeah. So now, if we have to balance the scientific rigor with all information what we have about the immunology and try to see the clinical pragmatism in our day-to-day practice, there are so many tests, like Dr. Chaithra mentioned, NK cell, the decidual uterine panels, ANA, CRP, ESR, CD4, CD9, CD56, and HLA, T helper cells, cytokines, interleukins. Oh my God, if we ask all this to the patients will not even turn back to us. So what should be the, the idea, like when we prescribe for immune testing?
So basically, the history matters a lot here. So whenever we have a person who's been well evaluated for her hormonal, anatomical, as well as the embryo factors, then yes, we will start out with base immune disorder or the commoner immune disorders like the ANA. We definitely look for the NK cells, the natural killer cells in the endometrial lining. We will also consider doing thyroid antibodies, which is on the rise, and I'm sure most of you all agree, post-COVID, we have seen a spike in the number of autoimmune diseases which has come out. So thyroid antibodies, yes. So that would be my first line of investigations. Progressively, if we find any abnormality, say her ANA comes positive, and then I will want to evaluate her for her extended panel. Basic ESR, CRP, and certain ratios which proves that there is inflammation gives us an indication there's something happening in the background. It could be an infection or an inflammatory origin. So that calls for additional investigations. So when you do an NK cell analysis and we find out that there are certain abnormalities, we may have to dig a little more. The next line is where we will also consider doing the HLA of the couple. After that, we will also, and more towards the transfer cycle, that is where we will want to do the cytokine profile, which will guide us as to what extra immunomodulators would be required during the procedure or even way before, say around 5 to 6 days even before we do the transfer.
Can you just elaborate the cytokine testing, Dr. Chaithra?
So when we do cytokine testing, like we all know, Th2 predominance is what is needed for a successful implantation. So when we do the analysis, we look for the good ones and the bad ones. So the tumor necrotic factor, interferon gamma, the interleukins, multiple signaling proteins like interleukin 6, 2, 10 is what is evaluated. This will tell us if we have a predominance of a Th1, it calls for suppression. So this is the women who will be benefited by giving steroids before the transfer. Now if we have very good Th2 mediated response, I don't want a clean response also because that also interferes with implantation. So if she has 0 of TNF and interferon gamma and the other inflammatory markers are also guiding us towards creating a baseline inflammation to help implantation, that patient may benefit from giving lipids. So that is how a cytokine profile will help us.
Yeah. So would you like to highlight about the high noise, poor standardization tests?
So yes, peripheral NK cells would definitely be my top priority. And as we progress, the cytokine profiling and the HLA, but has to be done stepwise.
Yes. So one thing is we should not be jumping to do all the tests at the same time. Maybe as Dr. Chaithra said, this should be the take-home message. We should do it in a systematic way, stepwise manner of evaluation for immune problems. It should not be that we give them the full panel. So we go with few cases. This patient has come with recurrent first trimester pregnancy losses. She has a ANA positive test report, but she doesn't have any defined autoimmune disease. Now, should we treat this antibody? Should we treat the clinical history because she has a recurrent pregnancy loss? Are there any other tests which we have missed? Or should we just go ahead with the ANA test report?
ANA being positive is a surrogate marker that there is an autoimmune disease happening inside. Now, should we treat her? Has to be individualized. Every treatment has to be customized for that one particular patient. So if she's having a low titer positive with no extended panel, now if she comes with an ANA positive with a very low titer, or when I did the extended panel, most of her antibodies came negative. If there is an autoimmune disease, it calls for evaluating other autoantibodies like APLA. So after evaluating all these, having a low titer, and it is considered around 15 to 20% on Indian healthy women will have a positive ANA without any symptoms and also not interfering with the process of implantation or pregnancy progression. But a high titer on the other side, 1:320 and above, associated or additional antibodies, Rho, La antibodies, thyroid antibodies, if she has multiple euploid transfer failures, that calls for immunomodulation. And when we say immunomodulation, we need to give her immunomodulators even before we go ahead to do the transfer. That does not interfere with the process of oocyte retrieval. But before the transfer, a good 60 to 120 days of exposure to HCQS has to concentrate. It's an intracellular medication for it to concentrate into the cells. So that calls for priming, and if required, guided by cytokine profiling, we can add additional medications like lipids or steroids.
So you feel that the antibody testing is aligning with the phenotype?
Yes, ma'am.
Yeah. So coming to the second case, here she's had recurrent implantation failure, and the immunological factors, if they have to be considered, how is it like, whether we should be doing or should we go ahead only with the empirical treatment?
Here, a repeated euploid transfer definitely calls for an endometrial tissue profiling has to be done. Not just the CD 56, 19, 4, 3 will guide us. So by doing these additional cells, it kind of helps us to decide how we have to progress. So here, TRAC cells estimation will help us.
Yes. So coming to this last case, this lady has had uterine biopsy for the NK cell, and the NK cell activity is high, and there is a T helper 1 dominance. Now, which should be the ideal immunotherapy?
So now we know it is a Th1 predominance, which means she is going towards a pro-inflammatory response. So here, with NK cell activity being high in the background, she has to be primed. A priming with HCQS for a minimum of 90 to 120 days. Followed by that, I will want to exclude pre-existing infections in the form of torch, chlamydia, endometritis of the endometrium. A CD138 will really play a role here. Then put her on a low dose of steroid. Ideally, we use around 7.5 mg, required based on her weight, even step it up to 10 mg.
Yes. So now we'll also go through this case who has had antiphospholipid antibodies, and she continues to lose her pregnancy in spite of giving her aspirin and low molecular weight heparin, which is the treatment of choice. Now, should we add anything else like HCQS?
Yes, ma'am. Here, again, it is way too required for her. She is a resistant case. So it is called for giving her immunomodulators, prime her, give her a therapeutic dose of anticoagulants. Also, if required, we may consider IVIG in her case. And in spite of that, if it is going bad, a refractory APLA, then she will benefit from rituximab.
Yes. So like it is not exactly like what Sir said in the morning. So Sir said, like it is not that, we are doing something and that is why we need to do the testing. There is some scientific basis for testing and giving the right treatment to the patients. So IVIG is still the treatment of choice in certain limited cases. That is what we should keep in our minds.
So mainly IVIG, if indicated, expensive drug. We don't have a lot of clinical trials. But where is it indicated? It is indicated if the patient is ANA positive, ROLA antibodies positive, and the baby is started having the conductive cardiac defects, then yes, it is indicated to give her IVIG once in 6 weeks. Apart from that, a catastrophic APLA patient will respond very well by giving IVIG. The other cases are unexplained causes, and after basic immunomodulation, failure of implantation should also be considered for an IVIG.
Yes. Now, a lot has been spoken about this lymphocyte immunotherapy, LIT. Patients have read about it, then patients after implantation failure, maybe like after the second implantation failure, they're not ready to wait to go through one more failure. So some of them have even come back asking, doctor, should I take LIT? Now, what should be my answer? Like, she has done her basic immune testing and it has turned out to be negative. So we don't know the exact reason why she has failed in her 2 previous cycles, but should I offer LIT for her?
It only depends on what is the reports. We will do her HLA of the couple. HLA of the couple, when I went out talking about the more financially effective one is the CDC, where we look for blocking antibodies. And if the blocking antibodies are less than 20%, she will benefit from LIT, the lymphocyte immunization therapy. The other way of doing this is the extended panel, where we do the HLA A, B, C, DRBQ match between the couples. The more the homozygosity or the similarity, the higher chances of rejection and implantation failure. Even they will benefit from LIT. Now, how it works is the lymphocytes, which is extracted from the father, is going to be carrying the CD200, the initial cells which are going to be presented to the maternal immune system. In the endometrial lining, you have the dendritic cells, which is going to recognize this lymphocyte, and it will trigger or increase the production of the Treg cells, the peacemaker cells. So once the peacemaker cells increases, the chances of acceptance is much higher. But ma'am, after 2 euploid transfer failures, ruling out all autoimmune disease, it is worth considering doing a HLA, the CDC testing for them.
So maybe, if the patient has to be offered LIT, do the testing, do the compatibility testing, and then only decide on LIT. Now, even about this LIT procedure, there are some, I would say like low-cost procedures and high-cost procedures for LIT. What is your take?
What we follow is a low-dose LIT. We do 2 doses of LIT 15 days apart, wherein around 20 ml of the paternal blood is extracted, and we extract the lymphocytes out of it, and we administer it in 2 different areas on the forearm. And why the 15 days gap is to give a build-up of the blocking antibodies. And we would suggest you continue after 20 more days.
Yes. Yes. Last part, like we heard about the stem cells. Do stem cells have a role in immunology?
In gynecopathology, the researches are still on. Yes, it's an immune booster, but still in the field of implantation failures and RPL, no clinical evidence is still proven.
Yes. So coming to the last part of the presentation, see, immunology is not very, very simple. It has to be understood completely to decide on what treatments have to be offered to the patients. There are many drugs which are there in the market. Just because we don't know the answer why the implantation has not happened, it doesn't mean that we should give them all these new drugs like tacrolimus, thymosin alpha, and GCSF, and also this Janus kinase inhibitors. But when should we start these drugs?
So common ones, HCQS we've already understood, steroids we've understood, lipids we've understood. Tacro on the other hand, it is a calciferol inhibitor. This mainly acts by increasing the Th2 response in the system. So a cytokine profile can guide us if a tacrolimus can be administered. Tacrolimus is usually started at around 0.5 mg BD. Progressively, after 2 weeks, we can increase it and go up till 2 mg BD. That is what we do follow. As far as thymosin alpha is considered, there are many protocols which is suggested. They are supposed to be acting by increasing the Treg cells in the endometrial lining. So there are multiple doses which is followed. The most commonly used, and which does say that they have a better outcome, is 1.6 or 3.2 grams, which is given weekly, which is given 2 times a week, and that is started in the luteal phase of the previous cycle before the transfer is done. As far as GCS is concerned, it again increases the Th2 driven response. And the last one, ma'am, we have not used it. Clinically, we do not follow using it.
Yeah.
The last one will be IVIG. IVIG, I will insist, very selective patients are supposed to be given IVIG, only because IVIG carries its own risk of having DVT by itself. So anytime IVIG is suggested or given to the patient, have to be given with anticoagulant and antiplatelet coverage.
Yes. Thank you very much.
Thank you.
Thank you, Dr. Sunitha and Dr. Chandrika, for an excellent talk. I think 10 minutes is not enough to talk about immunology. Yes. But I would like Chaithra to just say what are the basic investigation, immunological investigation for the take-home message, which are ideal first step.
First,
if that is all normal, then we go to the next step of investigation. Would you just tell them what would be the basic?
So the first, most important, ESR, CRP, ANA done by an IF method, 1:100 titration. Also consider doing APLA for her if she's having first trimester losses post-cardiac activity, also the endometrial NK cells with thyroid antibodies. This will be the first line of evaluation. Only if I do not find much information in this, then we go to the second step, wherein we will also consider doing her HLA. The HLA, be it the functional assay or the extended panel looking for homozygosity. And then just way too, ma'am, very close towards transfer is where I will suggest we do cytokine profiling, which will guide us in the procedure during the procedure of transfer.
Embryo transfer.
So just in recurrent pregnancy loss alone.
Yes, ma'am.
If you are not planning an embryo transfer,
Yes.
would you still suggest the same method of
Yes, ma'am.
immunological investigation?
Yes, ma'am.
What would be the cost?
I've got so used to answering this question. So, ma'am, when we do a basic ANA costs us 120 rupees. An extended APLA
The whole panel.
the whole panel will be
primary
close to
investigation.
6, ma'am.
6,000.
6,000.
6,000. HLA?
Ma'am, HLA, what we do in Chandray is a functional assay. So we do it's 4,000. But if we are looking at the extended panel of matching the HLA A, B, C, that goes close to 30, ma'am.
And when will you give the GCSF, granulocyte CSF?
Ma'am, this is mainly in a person who's not having endometrial. If she's having a little problem with the development of the endometrium, she comes back saying that I've been having thin endometrium. And also if she's pre-existingly having a very high levels of TH1, so TNF and interferon gamma being high, those women we do suggest.
Otherwise,
No.
Yeah.
thank you so much.
Thank
for
you,
an
ma'am.
Excellent talk, Dr.
Thank you.
Chaithra.
Thank you. Thank you.
Thank you.
Thank you all.
Round of applause for both of them,
Thank you,
Sunitha and
thank you.
Chaithra.
Thank you. Thank you. Yeah.
I would like to thank Dr. Sunitha and Dr. Chaithra and the whole CFC team for giving us this opportunity to chair this session from both of us.
Thank
Thank
you.
you.
Thank you.